start with some kind of fourth week. Be reminded. Fourth week, what happens? You know this. Who is this? It could be me, you, anybody. You remember this. And we are focused today here. Before we were focused at this place. Now today we are focused at this place. Can you excuse me? Yes. So guys, I know what you did. I know what you did. Finish. End of the story.
What did we do?
I know it.
You can't say it.
I know it now. What you did. You see. What's that? Okay. Let's come back. So, look, my job is help in execution. When you get it, it's assessment office.
You seem happy.
They have their own mechanism. They go, they just do the things. They need so many. You know, when result comes to you, it comes after so many categorization. You'll be informed. You have to be told. So many things need to be connected. But primarily, we had a fake book. Anyway, yeah, in these professional exams, there is no pass or fail. And this midterm is for tell you how you are going. Right? Alhamdulillah, things are okay. Those who did good, they are mashallah good. And those who are not doing anything, they will see to it what it is. But it's fine. So our focus today at this place. Our focus is here, and that is the lower segment. So L4 to S3 is the area. And what is happening at this place, we have another limb part, which starts emerging. So now, we transform into it. We'll start with the blood supply, now. And you can see, the plan, the arteries and veins, who are connected to my lower limb. You can see there's a big artery. It's not axillary artery, it's common iliac artery. Common iliac artery, which becomes external iliac, which is visible to you. Shh, guys, please. So this becomes femoral when it reaches to your thigh. Because in thigh, most of the things, front of the thigh, they are given the name of femoral. And it gives so many branches here, and we need to know those names. And then you can see, it gives a branch like your brachial artery. You learn there a profunda brachii. Now, you are looking at this number 2 is profunda, again, femoris. That was profunda brachii, this is profunda femoris. It comes all the way down in front of your thigh, then suddenly it lost its way because it has to go back. It pierces. It pierces at this place above the knee joint, and then it's visible. Then it comes in front, when it crosses the knee joint. Then it comes in front. Obviously, it has to divide. So you can see this 4, what is this 4? And then it gives branches, front, the lateral side, and the posterior side. So this is the arterial plan. Veins, like cephalic, basalic, here we have great and lesser saphenous veins, or long or short saphenous veins. And you are looking at the long or great saphenous vein. It starts on the dorsum of the foot, and it goes all the way. It runs medially. It's under the skin. And it goes But it doesn't disappear anywhere, it's just going up, it stays medially and it is draining into my femoral. And then femoral become external, that become common, and common, two commons, they join to form my inferior vena cava at fifth lumbar vertebral limb. Are we good? Now let's see what is happening on the back. So when this artery, after piercing, reaches to the back, now we don't call it femoral, we call it now popliteal. And popliteal is further divided. And then you can see this, this was my great saphenous, this is my small saphenous. And this is how the blood supply across my lower limb is being organized. You're looking at the arteries, you're looking at the veins. Going further, we have this structure which is formed by two coxal bones. And two coxal bones meet together and they make something which looks like a round thing, like a basin, and this is the foundation of our trunk, and to this foundation my bones of my lower limb are connected. And you can see there are so many green arrows. These green arrows are showing us the pathways taken by neurovascular bundles. So many of them are leaving and their destinies are different. Everything is going out of this closed space and they have their different destinations. They are going in different areas. And that we will be learning throughout these 3 weeks again. Going further, now what are the movements? But before the movements, we should know who's moving them. So we talk about brachial plexus. Now today we'll be talking about a plexus which is a combo. It's not one. And it's not that organized the way we saw the brachial plexus, division, then trunks and this and that. Here things are very simple. From the roots, branches. That's it. There is no overlaps. But again we have plexuses. So the plexus which I'm showing to you, again I'm showing you 5 sources. These are my 5 roots, 5 spinal nerves. And then you can see them, L1 to L5. They are, so L1 divides directly, root divides into iliohypogastric and ilioinguinal nerve. These are the names, that's it. Then, the posteriors of L1 and L2, they give me a branch which further divides into genital and a femoral branch. And together they are called genitofemoral nerve. Going down, I have lateral cutaneous nerve of the thigh. The name tells you, it goes and supplies the lateral side skin of your thigh. Now this is an important nerve, which comes from my L2, 3 and 4. And that's the main nerve, we call it femoral nerve. It supplies front of your thigh. Like front of your arm, the nerve was musculocutaneous. Now this nerve which supplies here is the femoral nerve. Then from the same sources, we have another nerve. That's obturator nerve. So when we write L234, L234, but there's a difference of Raman. So this is my obturator nerve. And that nerve controls medial side of my thigh. In upper limb we don't have any medial side in particular. But here we have something in particular. So this is a nerve from a medial side. And then this is L4 and L5. They are contributing to the bigger plexus. And that bigger plexus is given the name of sacral plexus. So right now on top I was showing you lumbar plexus, and this green thing is just going and contributing to the sacral plexus. Are we good? So now, these are exactly we need to know where and what are they doing. We are not only supposed to know what are the names, but we need to know what are the areas and what is happening, which skin. So you need to be good with these small black things. Names, sources, and areas of distribution. I'm showing you a muscle. You remember for upper limb, I showed you a muscle. And the name of that muscle was spleniae. And here, the muscle here is psoas major. We write with the P is silent. Never call it for sauce, it is psoas. So this muscle is given the name of psoas major muscle, and this plexus is forming inside this plexus. This plexus is forming inside my psoas major muscle. And if anything goes wrong with the psoas major muscles, I can have a major problem with understanding and with functionality of my lower limb. So then these are the different parts, and now this is without the thing you are looking at. The same thing which I was telling you, anterior and posterior divisions, and you can see the branches which are coming from the different parts from L1 to L5, and that's my lumbar plexus. Going further, we can see its organization. In my first slide, I was trying to show you how the different structures are leaving the pelvic cavity, and pelvic cavity is a joint, is a union of my two coxal bone and a sacrum. They go together and they make this pelvic cavity, and you can see from this pelvis these different nerves are leaving, and these nerves are nothing but the branches which emerge from the lumbar plexus and they emerge from the sacral plexus, and they are going and supplying different regions, different muscle areas. Mustafa, you're sitting in the front seat and by habit you're talking. When you sleep, I'm waiting. When you go sleep, it's better for me. So we are looking at two plexuses together. On top you're looking at the lumbar plexus, and down you can see this has been contributing. So these two plexuses are primarily responsible to supply my lower limb. And this lumbar plexus is primarily for the front of the thigh and the medial side of the thigh. But the posterior thigh and rest of the leg and the foot, they all are innervated by this segment through a big nerve, sciatic nerve. Sciatic nerve is a byproduct from sacral plexus. It gets a contribution from lumbar plexus. So sciatic nerve is the chief nerve of your lower limb. Now, what are the different movements which may occur at my lower limb? So we can have so many movements. So these are the regions which we'll be looking at in this time. So we are having flexion, extension. I'm sure everybody is good with that. I'm trying to show you the axes. In which axis we are having these type of movements, and this you need to understand the names of the movements. If you are lifting your foot, we had a different name, dorsiflexion. We didn't talk about this. And once you are pushing your foot towards the land, towards the earth, we call it plantarflexion. We are pushing on the planet. So we have these two new terms, dorsiflexion and plantarflexion. So still your excuse is on. 30 minutes. Is it fine? So now these are two more terms, inversion and eversion. You are turning your foot inwards at ankle joint and outwards. Are we clear with these? So, what are you looking at? Cross section. Length, can you tell me what is this muscle? Are you length? You have changed your name? So then, if it's a call for length, let it to him. If I need you, I'll give you length. Huh? Really? Psoas major was a muscle, my dear, which was in your tummy. And you are pulling it down all the way to your leg. I didn't say anything. I asked you, what is this? Plus. Yeah. What is this?
Biceps femoris.
Then he will say latissimus femoris. So we are not sure. Okay, let's. Again, question for you. Don't ask him. You want to answer for him? No, if you want, I can bring question for you. There's no problem for me. Sabar. What is this bone should be? What this bone should be? Very good. So now at least I can see length is showing some improvement.
No,
but
you said muscle. You said muscle.
Okay. Okay, then what is this?
That's sciatic nerve.
Wow. I love you. Sciatic nerve, hollow inside like an artery. Or like a vein. So guys, so it is difficult for us to understand what is this. It's a section at my thigh level. So this is what it is. If we label it, this is how it was. And to understand this, we need to look at it. Do you remember this? Skin. And now we are changing. We are not showing you basilic and cephalic. We are looking at the long saphenous or great saphenous vein. And this green thing, this green ring is the deep fascia. Now, this is, can you see that? This green ring has become thickened at this part. This thickening in my deep fascia, it has a name. And that name says I can see that you are continuously talking to him. So after 5 o'clock, go to Panda, have fun there, continue talking like you were seen there before. So this thickening in the deep fascia, we give it a name, and this name is important. We call it iliotibial tract. Iliotibial tract. So this iliotibial tract is something which is really important, and we need to know in detail about this structure. I have one gentleman with us, Marwan, the guy who is sitting next to you with the red cap. Gentlemen, if you are here for playing some game, I can give you a big console, at least surf studio. You can have a more meaningful play outside. Why are you bothered? From 10 o'clock, so religiously you are playing with that. You know, in one night, I still remember of my younger brother. It was a big night, like it was kind of, in Ramadan, the last 10 days, Ashra Akhir. So it was a big night, and the whole night he spent playing with his, gadget. I said, it's better you could have slept. Why you are awake? Well, I was awake for it's a big night, you have to awake. I said, there is no need for that. So if you are not concerned with me, you can relax outside. I can pay for your coffee, your any kind of meal in between, and your screen. No problem, be my guest. So if you have any other concern, go and enjoy outside. So guys, this thickening in the deep fascia, we give it a name and we call it iliotibial tract. Abdul Qadir, you are bringing some coffee for him? No. So now we learn it. Then, you're not. It's your time for visiting a restroom. Go. So this bone here, we call it femur. Now guys, this concept is important. Before we were having anterior and posterior, but today it's not that story. I have 3 lines. And these 3 lines, Anas, do I name anybody individually? So, we have 3 compartments now. These 3 compartments are made by these septas. And if you really, when you dissect, I wish now you should start dissection. Your upper limb is done, and how much dissection you have done? Only removal of the skin. I have 0 problem. Day before yesterday, somebody came to me, any dissection needed? I said, Sabr. Otherwise, when you reach to your lab, not today, but next week, everything will be done. You want that way? I'm holding the people, no, this is for year 1, let them do it. Otherwise, year 2, year 3, year 4 are jumping. They say we have so many cadavers, they are not doing anything, show an evidence what they have done. I said, I'm sorry, they have not done anything, I feel sorry for you. But please, if you want to do, please do it. Otherwise, somebody else will do it. And we are not really waiting for you. Oh, you are coming. So guys, these compartments you may not see. These compartments has been set for the level of understanding. To make you understand, to make your life easy. Like we talk about the flexor muscle in the forearm. They were in layers. We had superficial, we had intermediate, and we had the deep layer. And that was only helpful for us to understand because we divide them, and that was helpful for learning the actions, for learning the nerve supplies, and for learning the other activities. And we were isolating them in different meaningful ways. So broadly speaking, this is my septum, intermuscular septum, same name, applicable everywhere. So who lives here? The hip flexors and knee extensors. So the muscle who lives here in this compartment, the anterior compartment of my thigh, primarily they flexes my hip and they extend my knee joint. So we always talk about with reference to a joint, and the nerve of this compartment is the femoral nerve. Are we good?
Yes.
So now the medial compartment, this is where my medial compartment, and their job is, they are adductors. For whom? For the hip joint. And their nerve is obturator nerve. Remember I shown you before? So their nerve will be the obturator nerve. And then coming to this posterior compartment. The posterior compartments are most commonly, I'm sure when you're watching your favorite game, soccer, there you'll see your favorite player, suddenly he's on the floor and he's lying down and he's in severe pain, and then it's been declared he has hamstring. You know this word? So hamstrings are those group of muscles who lives here, and their job is they are extensors for hip joint and they are flexors for knee. So when you're about to hit a ball, so you can see how meaningfully you're using these muscles. And if you see the good footballer, which you like to see them when they are in action, you all know, you all have your favorites. So you can look into your thighs and you can see how strong and how meaningful their muscles look like to you. And these muscles have shown these modifications. And their nerve is my tibial nerve. The tibial nerve is one of the chief components of my sciatic nerve. You remember I told you the sciatic nerve is the main nerve for my lower limb, and this sciatic nerve bifurcates into tibial and common fibular nerve. Your old books will write it as common perineal, but that terminology is gone. So now the tibial nerve is primarily controlling my posterior compartment group of muscles. Are we clear?
Yes.
Now again, this is another section, but this section is at the level of your leg, in your forearm, in other words. In the lower limb, we don't have forearm, we have leg. So in the leg, you have this section, and now it's not easy from here, but we have to draw it like that, and to understand, now what is this? What are you looking at? Hip joint. So it is which type of section?
Coronal.
Coronal, don't say transverse.
Coronal.
Coronal or frontal section. So you're looking at the upper end of the femur, the head of the femur, and it's going to a socket. This is a true example of a ball and socket. Previously the socket, it was just a shallow cavity. So but now the socket is very meaningful. So now, if I see this joint, how my patient will show you? My patient will not show you like this, I will see something like that. And from here, I have to deduce where is the problem. Make sense? So now, if I see under microscope, I have to understand something like that. So this is just, I'm showing you. Don't read it, just see it. Going further. Now, where is my hip joint located? In the bones, which are organized in my upper part of my lower limb. So these are the bones, you're looking at the coccyx and the upper part of the femur, and this is the broad view, and the joint between these two bones, which makes my, one of the classic ball and socket joint, that is also called hip joint. So this joint is, you are looking at its different ligaments. You are looking at its close-up. We take it from here, its close-ups, and you are looking at the different parts of these bones. And once we remove this head of the femur, inside the cup thing, where this head was going, this is how it is. And even inside, there is an anchoring thing, there is a support thing, which was keeping, which was making this joint. So this is one of the very stable joint of our body. So dislocation of the hip under normal condition is not occurring. But be reminded, while you are driving, if you have head-on collision, there is fair enough chance that you might have dislocation occurring at your hip joint. The reason, when you're driving your car, you are in a sitting position, and your knees, they are about to hit the front part of your car, and with acceleration, when you apply even brakes, you are bound to go and stuck with the dashboard part. And once your knee got stuck, as a result, you have two types of injuries, and I'm alarming those. You must have seen so many people here. I have seen so many, and especially Shabab. When they drive, one of their leg is being in that window. I wish no one like that is sitting here. If that person have a head-on collision, he will not only dislocate, he will also have a fracture at hip joint. So be careful. Everybody likes to sit, put your legs in air like that. But the consequences are so worse. And I will show it to you what can go wrong. Are we clear? So now, last leg, don't. I don't like to see you with that thing. Please, don't do it. So now let's see what happens in the legs. A quick review because I'll do it again. But now you are looking at two ways. Before we were only looking at the great saphenous, now you are looking at short saphenous or small saphenous. There is no elliptical tract. I have two bones, tibia and fibula. And then I have muscle compartments. So this is the first thing. And now you're looking at the defibular or tibial nerve. And here you have even this fibular nerve has its superficial part and deep part. So this we will learn in the section of leg. Now, this is someone's body. And you're looking at the bones, the part of the coxal bone, and these are, guys, these are palpable bony landmarks. Abdul Aziz, what are you looking in the screen? This picture is not there. Be rest assured. Don't tell me I'm reading through your PowerPoint. So you're doing anything other than this. Maybe watching Netflix. So, this is my coxal bone, and these are the structures which can be palpable. You can palpate your own bony landmark. Let's say you can palpate this point number 3 in your own body. You can palpate this point number 5 or 6.
Thank you.
You can palpate this part, but don't try to palpate. You're sitting on, right now you're sitting on this part of your bone. All of you are sitting on this bone at the moment. Moment, everybody has the same. So now, let's color it. So now, there are certain specific landmarks which have been introduced. And you are looking at an artery. This artery, we learned that the artery for my lower limb is femoral, so point number 4 is my femoral artery. But you will see it always like that. On an X-ray, and you have to be good on a given X-ray how you can differentiate different bones. And now, I'm showing you the different compartments, the different layers of my ligaments who makes my hip joint. And then I'm adding on muscles which are present. You can see how many muscles are just present in this small area. And then I'm making something like axilla. We had something known as femoral triangle. And femoral triangle with all its contents. Okay. That was just a gallery walk. Now let's start the real business. So the coxal bone, the hip bone, in the common words you call it a hip bone. You remember when we were learning about upper limb, we started with pectoral girdle, and we said your scapula, your clavicle, and part of your humerus, they together make your pectoral girdle. Same goes in the lower limbs, that is your pelvic girdle. And pelvic girdle is a combo of 3 bones. In the early life, these 3 bones were separate. They were not fused together. They were all different. And the big one, which is shown with the green color, we call it ilium. And this one, with this brownish shade, ischium. And this one, gray, is pubis. And all these 3 bones, they merge in this big cup. That cup is given the name of acetabulum. And you can see that this, if you see some X-ray like that, you can immediately your answer should be, this is a bone, this is an X-ray of a minor. Someone who has not reached to a level. So the bones is not broken. The bones have not fused. You remember we talked about epiphyseal lines? So the bones have not fused together. And once you see an adult, you will barely unable to see that where these lines were. You can guess upon, but you cannot be very clear that how and where what is happening. Am I clear? Yes. So we need to understand these. Where is ilium, where is ischium, where is pubis. So now let's label it now. That's important. So these labels are ilium, iliac crest. And this is a very important landmark. It is anterior. It is anterior. It is superior. It is with ilium. It looks like a spine. So I call it. So this is my posterior. And this is my anterior. I didn't read it. So this is my posterior superior iliac spine. And there is my anterior superior iliac spine. And now this is below to it. What it should be? Posterior, inferior, iliac spine. And now, I just told you the name of this bone. Pubis. Very good. This is where you're sitting. ischium. And this is acetabulum, the cup, where head of the femur goes and articulates. Femoral head. And this is, yeah, thank you, this is neck. But this is not, now we don't call it tubercle. It's bigger than a tubercle. Trochanter. So the story started from a tubercle. Now the tubercle, the bigger version of the tubercle, XL version of tubercle, we call it trochanter. So we call it greater trochanter, and then what do you think number 2 should be? Perfect, you guys are smart. And there is a line between greater and lesser. Intertrochanteric crest. We'll use the term posteriorly, we'll say the crest, anteriorly we'll say the line. So now, so the weakest part is this ligament. I'm not showing you at the moment. So now, someone has fractured. Remember, we don't put plates on scapula. If someone fractures scapula, you have seen it, how thin it is. Where you put the plate and where you tighten the screws. There's no place to tighten up your screws. But these bones are solid, and I'm sure somebody who was teaching you the place from where you can aspirate bone marrow. You are told about these landmarks. So these bones have been commonly used. If you're not having access, you don't want to disrupt the sternum, you can go to this ileum, it's safe. So now, you're looking at different fractures and different type of screws, how we use to fix these different broken fragments of these bones. And this bone needs to be fixed. Now, what's wrong?
Where is this pubis?
See, there is something wrong here.
Yeah, where is this pubis?
So we have to look into that. So now what are these bones? Femur. So the head, this bit, fovea for ligament of the head. You remember you were shown an anchor?
Yes.
You were shown an anchor into the cup. That anchor comes and fits here. And that anchor is given the name of ligamentum fovea or ligamentum of head of femur. So that has been a very strong connection, which keeps this head in its position. It's not like my shoulder joint, which is very commonly dislocatable. The hip joint is something, if it dislocates, you need super energy. To dislocate your upper limb, your shoulder joint, it's a matter of 2 minutes. But for dislocating the hip joint, you need power, you need impact. So now the neck, head, people were talking, greater trochanter, lesser trochanter. And now we give it a name. There is a place called pectineal line, gluteal tuberosity. This is a rough area where I have the attachment, the distal attachment of my gluteus maximus muscle. It's one of the big muscles which makes the bulk of your butts. You love to eat steaks. Usually they give you a big part of meat. It might be gluteus maximus. It's a very big, you feel on your butt, you have a big muscle on your back, that is your gluteus maximus. You can make a sound out of that. Chef, don't try it here, try it out. So guys, again we have supracondylar area, be careful. We have again supracondylar fracture. So don't think it's on, there's no median nerve here. That story is changed now. So these are my condyles, lower end of the, there is no trochlea, there is no capitulum. So this labels, I don't think there is any problem. If you have, please discuss with me later. Not now. So now, let's talk about anteriorly. Let's see the things, how the structures are coming. We know these bones. Just a recap. So guys, there is a fibrous communication. This fibrous communication, which is shown with this green color, that is given a name. It's called inguinal ligament. This region is given the name of inguinal region of our body. This ligament, actually, it's a part of a muscle. This ligament it's one of the very important and a very key ligament in human body. When you are exploring someone's abdomen, when you are doing a surgery in the lower abdomen, inguinal ligament is one of the very famous reference points. So this inguinal ligament is lower free part of a muscle which lives in my abdomen. And this muscle is given the name of external oblique. External oblique is the name of a muscle. Which, you know, when you are trying to show your 6 packs to the people, if you have, I'm not saying 12 packs. So if you have 6 packs and you are showing to the people, why are you looking at him? Even if you see you are not having 6, you will also have 8. You know about 6 packs and 8 packs and 12 packs? 12 packs when we have layers and layers and layers. And 6 packs when everything is in the fat is away. So this green thing, Khalas, you also have 8 packs. Don't target on someone who has more than you, but so this ligament is lower free border of external oblique muscle. And how it is happening, we'll talk about it. Just relax. Just know the name. I'll explain it to you, but not right now. So this ligament starts its journey from anterior superior iliac spine. It goes obliquely to the pubic tubercle. Then it deviates backwards and it changes its name. And then this is my anterior inferior iliac spine, and this is my head of femoral head, and that's acetobulum. They are good so far. This is the neck, very important. The head of the femur is similar to your scaphoid. The similarity between these two bones is both of them are highly susceptible to go under avascular necrosis. So now, greater trochanter is number 1, lesser trochanter, we know about these names, and this line we are good with that. And now what I'm showing you. Capsule, who makes my hip joint. And then a ligament which comes from my anterior inferior iliac spine, and it comes to this line. What is this line number 3? Intertrochanteric line. So we call this capsule was number 1. Number 2, iliofemoral ligament, because this ligament extends from ilium and it goes to the femur. We call it iliofemoral. It means I'll be showing you someone who comes from the pubis, someone who comes from the ischium, and their names will be ischiofemoral, pubofemoral. So if somebody asks you, name the ligaments of the hip joint, your answer should be the capsule, fibrous joint capsule, iliofemoral, ischiofemoral, pubofemoral. So let's put everything together. So now it's coming from where? What was this bone? Ischium. Ischium is here, guys. So this is, I cannot show you the other one. The ischiofemoral, I have to go on the back side. This is the front view of my hip joint. What is this blue thing? This is the bursa, and this lives in this gap. Now ischiofemoral I cannot show you here. I will be showing you shortly. Next slide. So now these are the ligaments.
The hip joint.
Abdurrahman. So these are capsular ligament. Their job is to reinforce. Their job is to reinforce the capsule. So now ligament of head of femur. I showed you when I was showing you the cup. I cannot show you at the moment. It is inside. So this is an intracapsular ligament. And now there is a muscle which comes from this place, from this opening, this hole, obturator, externus. We have an obturator internus also. So now a muscle which comes from my pubis bone, and it is going to the medial side of my thigh. This muscle should be a muscle of one of the adductor, and that muscle is given the name of adductor brevis. So when I use the term brevis,
There is a longest.
there must be two more, magnus and longus. Now there is an artery. Who this should be? Femoral. And here? External iliac. External iliac, I told you, femoral ligament, this inguinal ligament, it has so many names. Inguinal ligament has so many, it is the cutoff point. The moment my external iliac artery passes under this inguinal ligament, its name has changed to femoral artery. Before it was external iliac, now we call it femoral artery. Then it is giving up its profunda femoris branch. We also call deep femoral artery. Then it's giving its further branches. We are not targeting here, but this is the medial circumflex femoral. You remember we talk about anterior and posterior circumflex humeral. Now we are not using anterior and posterior, we'll be using medial and lateral. Circumflex humeral means they are surrounding. So this is my medial circumflex femoral artery, and this must be lateral. So you have medial and lateral circumflex arteries, and they are surrounding what area?
Capsule or neck.
Neck. We talk of bony landmark, neck of the femur. And then you can see it gives so many branches coming from this lateral. These are given the name of, now you need to know the name of the arteries. Retinacular arteries. And then I have another artery which is going downwards, transversely, inferiorly, and they are transverse and descending branch of, what is this? Left circumflex femoral artery. So my this, it gives a transverse branch, it gives a descending branch, it also gives an ascending branch. It goes same for both. So now, from where? From my femoral artery?
No.
From my external iliac artery. I'm showing you branches which are given in the pelvic cavity, and who are these branches? And they are, this branch is contributing to this. Can you see there's a ring form? So this branch is communicating, and it's coming from my external iliac, and this branch is inferior gluteal artery. Why we call it gluteal artery? Because it is present in back of my thigh, not thigh, in back of, in my buttocks, in my gluteal region. That's why it's given the name of gluteal artery, and I said it on purpose, inferior gluteal artery. It means I must have a superior gluteal artery. So now, first perforating, where is that? Where is my number 1? Number 4, can I show you any 4 number? This one, this one. And then, this my first perforating branch. Why I call it perforating branch? It perforates the muscle. It perforates the muscle. Can anybody like to give me his notebook? Can you give me anything? Hold on, Waleed, you give me, your book is small. I need a small book. Now, Mohammed will jump from here to this. Now go back like this. So guys, everybody should not try like this. And I don't want to name people, those who don't want to try this. So guys, you need something? Then why you're asking me? So guys, I know you're sleepy. Ali is sitting next to you. He'll make you awake. Don't worry. You're surrounded by my people. So guys, look at this notebook. If I open it, the pages are attached to a place. The same pattern. These muscles, big muscles, these adductors, adductor longus, brevis, magnus, they are attached to my femur bone. So all these muscles, they start their journey from this part, the ischium and pubis, especially from the pubis, and they are going to the femur, and they are going like these layers, these leaves. And this is how it makes. I don't want him to jump and break his leg. I know you are doing it every time. You want people to clap for you? See, Mama, they love you, okay? So, but don't try it every time, otherwise they feel sorry for you if you break your leg. So, guys, this is my first perforating branch. I need your attention. I'm developing something which is very, very, very important. And can you see a circle is being made? Everything is going to this circle. And this circle has some meaning. And that will be coming up. And if you're not connected to that, then you will be confused what came. Then the next question will be, can you repeat this? So don't ask me that. So my first perforating branch, which was coming from my profunda brachii. So this branch is going and is contributing to this circle, which is made by my lateral medial circumflex femoral arteries. And this circle is made around the neck of the femur. And I told you, the head of the femur is another part which can undergo very easily avascular necrosis. So I'm trying to bring you to that point that what will happen next, and we need to understand that part. So now you can see it's ascending branch. From where? From my first perforating. It perforates this muscle. What this muscle was shown to you? We call this muscle as adductor brevis. Right? So this adductor brevis is pierced by my first perforating. When I say my first perforating, I have second perforating, I have third perforating, I have fourth perforating, and I have terminal perforating. Then this femoral artery, it turns into further terminal. So then my first perforating gives an ascending branch. Is it not ascending up? And it's going to this circle. This whole circle is very important. And now, 1 to 4, trochanteric, cruciate anastomosis. In between my trochanter's, I have an anastomosis. I have a place where so many arteries are joining for a purpose. And that anastomosis is given the name of cruciate, trochanteric. There are so many names. We need to sit down with these anastomosis, how they are formed. And we need to be good with this. So they are all contributing, all my perforating branches, they all are contributing to this anastomosis, this circle. And I have 3 types of anastomosis here. I'll not be showing you at the moment. So now, a nerve coming to my medial compartment of my thigh. This nerve should be obturator. Thank you. So this is my obturator nerve. What happens? Obturator nerve, when it reaches here, after emerging from my lumbar plexus, it bifurcates. Because adductor brevis muscle was in between. So let's say this is the adductor brevis. Obturator nerve reaches on top of it. One part goes in front, one part goes behind. The part which goes in front, we call it anterior division. The part which goes posteriorly, we call it posterior division. So my obturator nerve is showing an anterior division and it shows a posterior division. And both of them, they are overriding adductor brevis muscle. Adductor brevis is a cutoff point. On that point, my obturator nerve bifurcates into anterior and posterior, because one has to supply in the front part, one has to supply in the posterior part. So posterior and anterior divisions, and they are happening because of adductor brevis muscle. And now you are looking at the femoral nerve, and now it comes down, it bifurcates into its branches. The femoral nerve has so many branches. Are we good so far? Anything which bothers you here? I will tell you when break. I will break you, but let me finish this because they are connected. So this is the muscle. This is the muscle which Leith was looking at this place. This is the psoas major muscle. Psoas major. This is the muscle of your back. It lives in your abdomen. So when it reaches to the ilium, the broad part of the ilium, a big muscle like subscapularis, a big muscle coming from the iliac fossa. It is iliacus. Iliacus blends with the psoas major, and together they are formed ilio-psoas tendon, and this is going towards my lesser trochanter. And this muscle has very important function. The function of this tendon of iliopsoas is really, really important. And that will be explained when we talk of fractures across the femoral neck. Femoral neck fractures is one of the key features of lower limb. Knee joint, number 1. Femoral neck, number 2. If you are not good with these two parts, out of a big number of exam question, you will be losing significantly. And I'm telling you, today you have seen 60 questions. Out of these 60, 40 questions were from anatomy, 20 questions from physiology, and out of this 20, 10 from development, 6 from histology, the remaining from upper limb. And now, in the lower limb, you'll have a significant questions from upper limb, from lower limb, and the number will inflate, it will go big. And from development, from histology, from physiology. Right now, 2 people were teaching you. One was Hamadan and second was Moni. Now you'll have 2 more people, Ahad and staff. So 4 people, their questions, Oni's questions, Paul's questions, and mine questions. They will all together, and that will make your final exam. So be ready. And then your OSPI, there will be 20 stations. And out of that, a significant number will be on cadavers. Now, if you think missing evening lab, you'll enjoy that day on 13th of November. And then there will be SAQ, 2 SAQs from anatomy, 1 from upper limb, 1 from lower limb, and then 2 SAQ from physiology. So be careful. This exam which is coming up, it's big, and you need to tie up now. Your freedom time is gone. Now you can break. Sir, I have no time for extra thing,